A very good afternoon to one and all. I am Arpita from the IGCP group. We are privileged to have with us Dr. Ashujit ji, a distinguished figure in the field of obstetrics and gynecology. Sir holds an MBBS and Diplomat of National Board in Obstetrics and Gynecology. He has pursued advanced training with a fellowship in minimal access surgery from the World Association of Laparoscopic Surgeons and holds a diploma in gynecologic endoscopy from prestigious institutes like the Kiel University in Germany and IRCAD in France. Currently, he is serving as a senior consultant in the gynecology and obstetrics department at PD Hinduja Hospital in Mumbai. Sir is widely recognized for his expertise in managing complex gynecological cases and minimally invasive surgical techniques. His depth of knowledge and experience uniquely position him to speak on the crucial topic of management of the third stage of labor, a critical area of ensuring maternal health and preventing complications during childbirth. With that, I would like to welcome Sir to this webinar and would hand over the session to you, Sir. Over to you. Sir, please go ahead. Hello, sir. Am I audible to you? Hello. I think sir is having some network issue for which he has left. Um, Let us wait for some time. He will be joining soon. Sir, there was some network issue. You can. Yes, sir. It's visible. Visible, sir. Please go ahead.
Sorry for the interruption. So today we're talking active management of third
Sir, can
stage
you
of
please be a little louder? Your voice is not very clear to us.
labor. So today we'll be talking about active management of third stage of labor. This is something which becomes very important because time and again we come across PPH and we think about how a hemorrhage can affect the life of a woman. So we need to know about this AMTSL so that we can reduce the incidences of PPH around us. So, as Antonio de Saint-Exupéry once said, time for action is now. It's never too late to do something. So, we need to act quickly. And once you know that these are the steps and these are the things that you need to do, so as in order to prevent PPH rather than managing PPH, that becomes a cornerstone in treating a patient. So, why are we discussing this? Because this is the most interventional thing that you can do to prevent PPH, because the incidence of PPH is 11% globally. And as we know, you and I, that PPH is potentially life threatening. And it is a preventable cause. So even though we see so many issues of PPH in our lifetime during managing cases, this can be treated, this can be prevented more than that. By definition, you can have a PPH in a vaginal delivery or a cesarean, depending upon the bleeding that happens, with or without the signs of shock. Active management of third stage of labor is recommended series of steps. It's not just one thing, but there are three things actually, which is developed by WHO, which are recommended that you do it so as to prevent PPH. Why does PPH happens? Because the most common cause is uterine atony. Uterine atony, which accounts to around 70 to 80% of cases of PPH. The other causes of PPH can be traumatic tissue, as we all know, but atony is the most common cause, and this can be reduced by using uterotonics. Uterotonics are agents which will help in contracting the uterus, and it is one of the first line interventions that we usually follow to prevent PPH in cases of uterine atony. And the most common drug that we all use is oxytocin. Nowadays, we have carbetocin also, which is a heat sensitive, heat labile thing, not a heat labile thing. So that is why carbetocin is preferred. But oxytocin is a uterotonic of choice to reduce the incidence of PPH and is universally recommended for all women. Third stage of labor is defined as the time between the delivery of the baby and the expulsion of placenta. The duration can range anywhere between 6 to 30 minutes. Why does or how does it happen is when the placenta comes out, the capillary hemorrhage, which is there around the placenta after the delivery of the baby, they start shrinking along with the uterine contractions. And then the bleeding slowly stops up. If the capillary vessels do not close or if the sinuses remain open, then you can have, because of atony, then you can have a very bad bleeding, which can lead to postpartum hemorrhage. Some degree of bleeding is always expected at this stage, which can range to 100 to 250 ml of blood loss. But once it increases to around 500 vaginal and 1000 in cesarean, that is when we label it as PPH. This bleeding, whatever little happens, is usually reduced or restricted naturally as a physiological thing by uterine contractions and activation of coagulation system. So we need to follow the AMTSL so that we reduce this bleeding and adding an extra boost to whatever the body does naturally. So what can we do is firstly we administer uterotonics right after the delivery of the baby. We either wait for the expulsion of placenta or the other thing that we do is controlled contraction. And the third thing is uterine fundal massage after the expulsion of placenta. Each has its own implications. There are different recommendations that can be done, and that is what we'll be touching on in the next few slides. The drugs that you can use are oxytocin, methergin, which are different. That's the thing that we commonly use with the generic name of ergometrin. Misoprostol can be used, and tranexamic acid, which can be used to reduce capillary bleeding. Of this, the one which is recommended by all the organizations is oxytocin, which can be given in a normal saline or in any IV fluid. And if it's difficult to find an IV line or if there is some faulty IV line, then you can also give it IM, intramuscular. The other things, methyl ergometrin, they have their own benefits and contraindications also. So if it's not like someone is not aware about this, then we take a step back. That is why it's not the recommended thing. Misoprostol, yes, this can be given. This is usually for me my second line of treatment. Once the oxytocin is started, the second thing that I move on to in cases of PPH is misoprostol, which can be given either per rectal, it can be given sublingual also. Tranexamic acid is not very useful. It is suggested that it reduces capillary oozing, but not very active in cases of PPH. So oxytocin is the one drug of choice, which is one of the high alert medications, and it can be given in an IV drip. Infusion can be started. It has to be labeled well so that you're not running the oxytocin along with a hydration fluid together. It has to be labeled properly. The important thing is the oxytocin has to be stored in a cold environment in a proper temperature of 2 to 8 degrees. The benefit with carbetocin that is available nowadays is that it can be also stored at room temperature. So that's the other thing that is currently not in the guidelines, but soon will come into picture. According to all the guidelines, this is one of the best things that can be done. Once the cord clamping is done, you give the oxytocin, and this reduces the incidences of PPH. Deferring administration of prophylactic oxytocin until delayed cord clamping had not been associated with any significant risk of hemorrhage, but then it's always preferable that you give the oxytocin as soon as the cord is clamped and cut and the baby is handed over to the pediatrician. So that's one thing that you always do spontaneously as gynacs, that the cord is clamped and cut, and the anesthetist or you have an assistant or you yourself will always say that please administer your oxytocin or run it fast so that the contractions happen and that reduce the incidence of PPH. Contraction was initially recommended by WHO, but currently this is something which is not as a proper thing but can be given as an optional. The issue with this is control contraction, if it's not done by an expert, you can actually pull the placenta along with the cord directly before the separation of the placenta. And this can lead to uterine inversion, which can add to your risk of PPH also, and it can lead to neurological shock for the mother. So that is why you have to be very careful deciding upon if you're supposed to be following control contraction or not. The studies have shown that it can reduce the mean blood loss, but then the current guidelines, whatever, even the WHO says that it can be used as an optional thing rather than a confirmed thing for reducing PPH. The third thing is uterine massage, or specifically, as per the guidelines when it was introduced, it was said that we do the uterine fundal massage once the placenta comes out, because that will lead to stimulation of extra endogenous prostaglandins, and that will lead to contraction of the uterus. It again was introduced in 2007, and by 2012, it became as one of the optional recommendations. Now, what we follow is uterine massage is usually used as a treatment. We all know that whenever there's a PPH, we start with the uterine fundal massage, and if it doesn't settle, we move on to bimanual massage. So it's used as a treatment of PPH and not recommended as a prevention of PPH. So women who are at a low risk of PPH, and if they want to avoid the use of oxytocin or avoid the active management of third stage of labor, or who are against this information and intervention, tell them that this is the reason why we are doing it. So what happens, they have usually read, and there are certain studies also which state that active management of third stage of labor is associated with increased pain because there is a very good contraction of the uterus that starts in. So that can lead to increased pain. It is also said in one of the studies that there might be an incidence of suboptimal latching of the newborns. And obviously, when you're doing all these procedures, the idea is that we want to have the skin to skin contact as soon as possible. But when you're working around these things, the skin to skin contact might take a while. So therefore, there might be interruption of breastfeeding or delayed in bonding of the mother and the baby. Therefore, the patient can opt against it. But then you always inform that we want to reduce the risk of PPH, and that is why we are following it. Once this is done, you can take the baby on the skin and continue with breastfeeding. Side effects, there are certain side effects which can happen basically because of the uteronic agents like oxytocin. It can lead to nausea, vomiting. It can lead to hypertension also because of the methyl ergometrin that we are using. If the placenta is not separated and you're putting it out before the separation by doing a controlled contraction, there might be incidences of uterine inversion. There's also a risk of leaving a bit of placenta behind if you're not waiting for it to separate properly. Neonatal risks are also there. If there is an early cord clamping that happens because you want to prevent PPH, you clamp the cord, clean up everything. There might be a thing which might be associated with iron deficiency anemia, or the baby might have anemia because of these issues. There might be intraventricular hemorrhage for the baby, or the baby might land up with hypotension. So these are certain risks, but not very important when you balance the risk and benefit ratio. But yes, you must be knowing about these things also. The other recommendations that the WHO says that it is important, whatever we learn about active management of third stage of labor, that the idea of whatever discussion that we are having right now, or in general, is that the providers or the ones who will be managing at the basic level, they need to be trained for this. Because without their training, even oxytocin cannot be administered properly. Even like the optional things that we have now, right now, like the control contraction or fundal massage that was there initially, have all become optional because if the training is not proper, rather than providing benefit to the patient, you might do actually more harm to the patient. Therefore, wherever you need to implement active management of third stage of labor, it's important that the providers are trained in these things. Always remember that when you're giving oxytocin, it has to be stored under the temperature guidelines which have been recommended, and you're not using anything which is outdated or which is not of a good quality, because again, the idea is to give benefit to the patient and not do something which is not effective at all. So therefore, if you're thinking about doing active management, offering a high quality uterotonic is important regardless of wherever she delivers. And again, the last point that again which I've written is that it's important that you need to increase the coverage by expanding number of women who are aware about oxytocins, and that we need to prevent PPH, so involving the ASHA worker, Anganwadi worker, the nurses, all these things act as a team that we can give a proper care to all the patients. So in general, what we've decided is that the idea is to reduce the risk of PPH. Therefore, active management is definitely recommended, even as per the most recent Cochrane analysis. Possibly, there are risks and benefits which are associated with active management. You can inform your patient about these things, but then go ahead with it, keeping in mind that managing a PPH is more difficult, which will require more drugs, more interventions, rather than doing an active management of third stage of labor, which is easy to be done. There are only 2 or 3 steps if you have to revise it properly, and you deliver it, making the delivery for the baby and the mother a beautiful experience. So thank you so much. It's a very small topic. So whatever you need to know is in this, the idea is to act faster, like I started with, because as John F. Kennedy said, that we must use time as a tool, not as a couch. Thank you.
Thank you, sir. Thank you so much for
So
your.
much for your
Thank you.
Now we would like to move on to the questions.
Sure.
So the first question that is coming from your experience, what are the most important preventive measures that can be taken to reduce the incidence of postpartum hemorrhage and improve maternal outcomes?
So the first thing that you should know is that you should be
So
able
can
to
you,
predict. Pardon?
sir, can you please be a little louder?
Yeah. The first thing that you should know is that you have to be able to predict PPH. Because once you know that these patients can have PPH, then you can manage it or actually prevent it. So, for example, if you know that there might be a large baby which might have shoulder dystocia, or if there's a precipitate labor, that scenario, or if you know that there's a bleeding coagulopathy disorder which is there. So these things become important, that yes, I'll keep my backup. Even for a routine thing, whenever we do a normal delivery or a cesarean in our setup, we keep things ready. So the wise option would be keeping a PPH box which has everything there. So in a PPH box, if you go through the guidelines also, we have right from a syringe to collect blood to the areas where you'll be taking the blood, the uh, bottles that you'll be collecting the blood in. You have a catheter which is there with the syringe and the distilled water, because you require to catheterize the patient. You have the methergin there. You have the oxytocin which is there in a drawer nearby in the ice pack. You have the misoprostol tablets. So all these things are there, along with an extra IV cannula, so that you have to put in a large bore cannula for managing PPH. All these things have to be ready. So you can never know when it can happen. Obviously, prediction is something which you know by experience, but as obstetric emergency, the name itself says it, that it can be an obstetric emergency. You have to keep yourself ready. You have to know the steps You have to work as a team. The first thing that happens in PPH is call for help. It's a team effort. So you have to have a team effort where everyone is trained and it's an ongoing process. It's not like you train for a while and then forget about it. So conduct mock drills, conduct these trainings, and that is how I believe that you can reduce the incidence of PPH in your practice. Next, please.
Yes, sir. Moving on to the next question. What are the most effective pharmacological agents for preventing PPH during the third stage labor, and what are the factors that influence their selection?
So for me, always it would be oxytocin first. We all know the benefits. It has the least side effects, and you can run in fast also. It can be given IV, IM, oxytocin, carbetocin. That's your call. The second thing that I usually jump into is misoprostol tablets. It does lead to a bit of shivering and nausea for the patient, but then it can be inserted per rectally. And if the patient is conscious and maintaining her senses, you can even give it sublingually, which works well. The action is quick. The other two drugs, which we all know, is methergin and you can give carboprost. The problem is each of them have their own side effects, and you'd have each of them have their own contraindications. So as you know that the carboprost is not given in cases where you have pulmonary issues. So then I would be scared in using cases of asthma. And again, it has this toxic dose. You can't go beyond 8 doses, and there has to be a time interval. Similarly, for methergin, you can't give in cases of Rh negative or cardiac issues or blood pressure. So if you know these things, then you can manage and choose and select whichever thing you want to. If you still ask me that if there's no contraindication, I would prefer oxytocin. I prefer misoprostol tablets. Then I prefer methergin. Then carboprost, because carboprost has a very bad nausea and gives rise to a lot of loose motion. So that's my last pick. So these are the four things which we know that we use in. Obviously, maintaining the hydration becomes important by IV fluids, which can be crystalloids or colloids, and blood in cases where it's required. So this is how you will manage a case in cases of PPH.
One question has come from Kasim Babar. Please tell about obstructed labor and labor with complication.
So labor with complications can be anything. Obstructed labor is when you feel that even after waiting, so it can be of different entities. You can have a Bandel's ring which is there, or you can have a DTA which is there, or the baby has got stuck because of CPD, which was not ruled out initially. So these can happen. And the issue with obstetric labor is obviously the uterus has undergone so much contraction that the lower segment will be thinned out. In such cases, either I have seen my professors doing a forceps delivery, but obviously you'll be damaging the vagina and the uterus if it's not done under careful supervision or experience. If you ask me, I will do a cesarean for such patients. If I get a call saying that this has happened and the patient has now moved to obstruction, and there'll be obviously fetal distress which is happening. There might be meconium which is there side by side, plus the obstruction that all we see. So in such cases, it's important that you catheterize the bladder. Again, prepare for PPH. When you're taking an incision, make sure that the bladder might be edematous. I have had incidents where we have gone through the bladder because the edematous bladder was being thought about as a peritoneum because it's that thick. So make sure that you dissect the bladder, push it down properly. Lower segment will be very thinned out, so suturing will be difficult when you're delivering the baby. Again, remember where you're taking an incision because the vagina, there's a very thin segment between the vagina and your cervix and your uterus because it becomes papery thin because of the obstruction. So you have to remember where to take an incision properly, the lower segment of the uterus. And once you're suturing, also make sure that things are aligned properly. In these cases, you might have to make sure that you reduce the PPH. You might have to do other interventions for PPH because it's an operative thing. You might require B-Lynch or uterine artery ligation, which depends on how much you can do it. But then side by side, continue with your drugs for PPH because you don't want things to become bad. So in this, I might also think of giving prophylactic misoprostol or a methergin so that I can just reduce the incidence and boost up your antibiotics because you don't want a secondary PPH with infection. So that is how you think about managing it. Keep the catheter on for a longer period because the bladder was also edematous. and monitor for the vitals because the patient can have PPH later on. So these are the ways that I'll manage it. Okay.
Right. So we have one last question for you.
Sure.
Could you please elaborate on the role of active management in third stage of labor compared to expectant management, and when one approach is pivot over the other?
Current guidelines also say that it's active management of third stage of labor. You can't have an expectant management where you are waiting for the PPS to happen. That's always a wiser thing to manage it. See, the idea is prevention is better than cure. So you have to prevent it rather than treating it. So active management is specific. You do a oxytocin. You can even give a methogen injection as soon as the delivery of the baby's shoulder has happened. That is also there in the guideline. Control contraction. If you're expert, do that. It's all preventing. See, PPH can happen at a very lower setup also, and we won't have all the equipment, we won't have all the necessary things which are required for managing PPA. So therefore, WHO and all the guidelines came in that we do an active management rather than sitting on it and waiting for the PPS to happen in and then expect to manage it. So I guess even the lecture dealt with the same idea that active management would be preferred over expected management of baby. Okay.
Right, sir. Thank you, sir. Thank you so much for answering all our queries, and we do not have any more queries for today. So thank you so much
Thank
for
you.
like all your knowledge, and thank you all. Thanks all the attendees for joining in and putting up their questions. Thank you so much once again to you, sir, for giving us your time. Thank you.